This is Sarah Keilman from the Education Subcommittee of the Cancer SIG. Thanks so much for joining us for the Cancer SIG webinar today. I just wanted to remind everyone we did receive approval from NSGC to offer CEUs for this webinar and for our entire 2016 webinar series. We're going to be keeping track of attendance for the webinar, so please don't worry about that piece. You do need to take a survey after each presentation, however, in order to receive CEUs for each webinar that you attend. So we will keep track of attendance, and paired with you taking the survey, everything should work out smoothly. The survey will be available as soon as the presentation is over, but if you're unable to take it at that time, you will receive an email later today from GoToWebinar with a link to that survey. We did have technical issues with that process the first month, but everything has been fixed, and last month went really smoothly. So today's topic is hereditary hematologic malignancies, and this is going to be presented by Sarah Bannon. Sarah is a genetic counselor in the Clinical Cancer Genetics Department at the University of Texas MD Anderson Cancer Center. Sarah specializes in GI cancers and leukemia, and she's currently the GC in MD Anderson's Hereditary Hematologic Malignancies Clinic. That clinic has now seen over 100 patients with leukemia in the 2 years that they've been around. Sarah graduated from the Stanford University Genetic Counseling Program in 2010, and she's now a head supervisor for the University of Texas Genetic Counseling Program, as well as serves on their advisory board. In her free time, she actually sings with the Houston Grand Opera Chorus. I don't know how she has free time, but I thought that was kind of cool. As Sarah presents, feel free to put questions into the questions or discussion boxes as you think of them. At the end of the presentation, Sarah will answer whatever questions you have, and there will be time for discussion. Everybody is currently muted, but I would be happy to unmute anyone if they'd like to participate in the discussion verbally, or if you want to ask your question yourself. So with all of that said, I'm going to go ahead and let Sarah get started and take it away.
Great. Thank you, Sarah. Thanks for that introduction, and I'm very excited to be presenting on a topic that I find immensely fascinating and also seems to be very prescient in our community right now. So I will get started. I don't have any conflicts of interest, and really my goal for this webinar is to give basically a primer for genetic counselors on hematologic malignancies, what are they, how are they treated, what to do when it pops up in a family history, whether that's the reason for the consultation or kind of something that shows up when taking a family history, the differential diagnoses for familial leukemia syndromes and when you should suspect them, genetic testing options, which have been lighting up our listserv, and the considerations therein, and then also just some unique ethical considerations that have come up in our clinic in the past 2 years that I know have come up in yours as well. So to start out, here is an overview of the hematologic or hematopoiesis system. And leukemia, which I'll probably refer to as basically blood cancer or heme malignancy for this talk to encompass everything, is a cancer that starts in the blood-forming cells of the bone marrow. So there are two lineages of the bone marrow. There is the lymphoid lineage and the myeloid lineage, which you see here. And the pluripotent stem cells are tagged either as lymphoid or myeloid very early in the development of blood-forming cells, which then mature through lymphoblasts, and in the case of the lymphoid lineage to primarily white blood cells, and in the myeloid lineage primarily everything else, so red blood cells, platelets, and a small subsection of white blood cells. So depending on where in this process a mutation occurs, someone can develop a blood cancer. If it is in the lymphoid lineage, then we see the lymphoid malignancies, acute lymphoid leukemia, chronic lymphocytic leukemia, Hodgkin's lymphoma, and non-Hodgkin's lymphoma, which I'll go through, and myeloid malignancies, AML, CML, which is chronic myelocytic leukemia, myelodysplastic syndrome, and myeloproliferative neoplasms. So leukemia cancer in general, I wanted to cover a little bit because I didn't feel like I had a good handle on what it was before I started seeing patients with it every week. So leukemia is really a space allocation issue. It is immature bone marrow cells that basically replicate too quickly. They acquire a mutation that causes them to become immortal, as we all know, and they inhibit the maturation of normal bone marrow cells primarily by taking up too much space. So the blasts or the stem cells replicate so quickly that they push immature bone marrow cells out into the bloodstream. So not only do you see an increase in cells in the bone marrow that can't do anything, but then the cells that are being pushed out into the bloodstream also can't do anything. So you see peripheral blasts in the bloodstream, but you also see decreased normal cells because the cells just aren't making it to that point. So acute leukemia is rapid onset and life-threatening when you have these increased blasts in the peripheral blood and the decreased normal cells. It can become a very dangerous situation in which someone can acquire an infection which they can't fight, or a clinical bleed because their platelets are low, etc. AML and ALL are the two most common acute forms of leukemia. Acute myelocytic or myelogenous leukemia, they're used interchangeably, is a relatively rare cancer like all leukemias. Leukemia actually is only diagnosed in 1 out of 4 in 100,000 people per year. And compared to other cancers, it is only about 3% of all cancer cases diagnosed in the United States and is the 11th most common cancer, so it doesn't even make the top 10. As far as AML is concerned, the lifetime risk for an average person is less than 1%, and most people are diagnosed later in life around the age of 67. And AML occurs in both adults and children. And acute lymphocytic or lymphoblastic leukemia, again, can be used interchangeably. ALL is the most common childhood leukemia. So whenever the kids are diagnosed, it's almost always ALL, but it can occasionally be AML. And you can see there that the median age of diagnosis is 14. So even though there is actually not an insignificant population that's diagnosed with ALL, over the age of 65 or over the age of 60. So if you look at the curve for the diagnosis of ALL in the general population, there's a huge peak in childhood under the age of 20, and then there's another peak over the age of 60. It's actually highly curable in children now, and it is highly lethal in adults at this point. So chronic leukemia is kind of the opposite. So it's still a space allocation issue. However, the bone marrow cells can mature, but not completely. And usually what happens is that the mutations that cause these leukemic clones happen at a later time down the pathway. So what happens is that you have cells that can survive longer than normal cells, and so even though cells can still mature, you end up having too many of the cells that should be there. And chronic leukemia is slow onset. It's rarely life-threatening. The two main forms are chronic myelogenous leukemia, CML, which is relatively uncommon, 0.2% lifetime risk, with, again, primarily affecting adults. One of the things that should be noted is that chronic leukemias are rarely seen in children. There have been reports in teenagers and people in their 20s, but primarily almost everybody who gets chronic leukemia is an adult. CML, we all learned about in grad school when we had to learn about the Philadelphia chromosome. Of course, it's often BCR ABL positive in response to Gleevec. But CML is a chronic leukemia that can transform to an acute leukemia. So sometimes that can occur, although it's rare. And when it does occur, it is called the Richter transformation. CLL is the most common leukemia diagnosed. It is usually diagnosed in older people, primarily men, at the age of 71. And it is essentially never diagnosed in children and leads to a very high white blood cell count, and I'll go into the treatment of that later. Myelodysplastic syndromes are another big area of hematologic malignancy, and they were historically considered pre-leukemia, but now these are a known hematologic malignancy that if, depending on whether it is low risk or high risk, untreated, can progress to an acute leukemia or by itself can be a problem in terms of making somebody immunocompromised, etc. And it's the same sort of situation as leukemia where the myeloid cells in the bone marrow do not mature. There can be, this is where blood cancers get a bad rap for being so many of them. There are multiple types of myelodysplastic syndrome, and based on their cytogenetics, their somatic mutations, they can be characterized as low risk, meaning low risk to progress to acute leukemia, or high risk, meaning high risk to progress to an acute leukemia, which in this case is always AML. Myelodysplastic syndrome can also be primary, meaning it just occurred as essentially a primary cancer, or it can be called secondary or therapy related. So you've probably all seen or heard of breast cancer patients or leukemia patients who go on to develop leukemia as a result of their treatment for cancer, and this is almost always myelodysplastic syndrome, which progresses to AML. So there is therapy-related MDS and AML risk with common chemotherapy agents that we all deal with, carboplatin, cisplatin, docetaxel, vincristine, et cetera, and radiation. So people who receive radiation that includes a large field, especially the long bones and the bone marrow, are at increased risk to develop a therapy-related myelodysplastic syndrome, which is usually within the first 5 years after diagnosis, but that tail of that curve is pretty long. And I think in general, depending on treatment, there's about a 1% risk to develop therapy-related MDS in patients being treated for breast cancer, for example. Myelodysplastic syndrome that is low risk usually just requires transfusion support or growth factor support to kind of bump up the counts in the bone marrow, and high risk MDS is typically treated up front with chemotherapy, and goes straight to stem cell transplant in the first remission. And so I've listed here the most common types of myelodysplastic syndrome. CMML, sounding like it should be a chronic leukemia, is actually a form of myelodysplastic syndrome. Bone marrow failure or aplastic anemia is another hematologic malignancy, which is, instead of a space allocation issue, there's too much space. So in this case, the bone marrow basically fails to make enough blood cells. This is just an inability to create the proper number of blood cells, not necessarily that there's anything wrong with them, there's just not enough. And aplastic anemia and bone marrow failure are interchangeable terms. And this is a very rare condition, about 2 to 4 cases per million. And we know actually a lot about them because of the bone marrow failure syndromes that are seen in children. So 5 to 10% of cases of aplastic anemia are hereditary. There are known causes to acquire aplastic anemia, radiation exposure, some medications and drugs and viruses, and about 10 to 15% of cases can be pinpointed to an exact risk factor, while 75% of cases are basically sporadic or idiopathic, meaning they haven't been assigned a known risk factor, nor are they clearly hereditary. The table shows the bone marrow failure syndromes of childhood and adolescence, which are also those of adulthood. And you'll recognize, of course, from medical genetics, the majority of them, including Fanconi anemia, keratosis congenita, Swashman-Diamond syndrome, all of these things which typically present in a pediatric clinic, because of multiple congenital anomalies, are now being seen actually in the adult leukemia clinic later in life. There is also a class of blood disorders that I answer a lot of questions about that we all deal with, which are myeloproliferative neoplasms, or MPNs, and lymphoproliferative disorders, or neoplasms, LPDs. Myeloproliferative neoplasms are an overabundance of a particular cell lineage. They are not cancers in the sense that these are not necessarily going to be life-threatening in any way. Like polycythemia vera, everyone has taken a pedigree where there's a relative with polycythemia vera, although interestingly, polycythemia vera can progress to myelofibrosis, which needs to be treated like a cancer. Essential thrombocytosis is basically too many platelets. Myelofibrosis is an overgrowth of the fibrotic tissue within the bone marrow, and CML is actually an MPN. Lymphoproliferative disorders, or LPDs, are our favorites. They're in every pedigree as well, which is CLL, Hodgkin's and non-Hodgkin's lymphoma. And these are B-cell neoplasms from that first lymphoid chart, if you remember back, that arise in lymphoid-rich tissues, like the lymph nodes in the spleen. So lymphomas are, in fact, blood cancers. Even if they don't involve the bone marrow, they arise from the same cells. So in most cases, The lymphomas will also involve the bone marrow. So small cell leukemia and small cell lymphoma often have disease in the bone marrow and in the lymph node where the cancer was detected, but not always. Hodgkin's lymphoma, non-Hodgkin's lymphoma, and CLL have long been suspected to have a familial component. So there have been several large studies looking at these familial lymphoproliferative disorder families. It's very unclear to what the single genes may be causing this. They haven't been discovered. I have more on this later. And basically about 5% of patients with CLL have a family history of leukemia, and there's actually a connection between all B-cell lymphoproliferative disorders, which I'll go into in a little while. So this is just a picture to give you a better idea of all of the different types of lymphoma that can occur. So this orange ring and yellow ring and white ring basically represent the places in which in lymphocyte-rich tissue, like in the spleen or in the lymph node, the B cells mature throughout their process to become all of their different types of B cells. And depending on where mutations occur in this maturation process, it determines the type of lymphoma that they have. So like follicular, Burkitt's, mantle cell, all of those are non-Hodgkin's lymphomas. And of course, if a B cell doesn't essentially make it to any of its maturation, it becomes just classic CLL. So I wanted to give a little bit of an overview of how leukemias are treated. Another thing I didn't quite understand before I started working in it, and it's very different from solid tumors. So for acute leukemia, there's no staging system. You either have leukemia or you do not. Chemotherapy must be started immediately, and interestingly, there's some behavioral research to suggest that patients with leukemia overall compared to solid tumor patients are less well adjusted to their diagnosis, even after anywhere from 3 to 6 months, as to that of somebody with breast cancer or colon cancer who felt a lump and then had to have an ultrasound and has a set of steps or appointments in which they kind of can become adjusted to the possibility they may have cancer. Often acute leukemia comes right out of the blue. Patients are admitted for intensive chemotherapy, myeloablative chemotherapy that begins almost immediately, usually within 3 days of diagnosis. And one chemotherapy cycle, which is typically 28 days, is often the only cycle it takes to put the patient into remission. So the goal is that one cycle of chemotherapy will induce a complete remission. And then depending on the type of acute leukemia, AML or ALL, there is then a follow-up phase of consolidation or maintenance chemotherapy, which happens somewhere over the next 9 months to 5 years. And that's also usually done in the hospital. Or after the first remission, if a patient is high risk due to their age or the cytogenetics of their leukemia, they go directly to a stem cell transplant after that first round of chemotherapy, which I don't go into much here, but is a very lengthy and involved process that involves moving and being in a local place for over 100 days, and it's highly risky, and so sometimes these things just happen very quickly for these patients. And the timing of genetic counseling and all of this is an interesting topic, which I didn't actually put in this talk, so next time. Chronic leukemia does not usually require any interventions up front. So you can usually monitor it by a CBC. Usually treatment is only initiated if a patient's symptomatic, which primarily is usually fatigue, night sweats, catching infections, that sort of thing, or if they're progressing. Usually they are just treated with drugs that reduce the high counts. And often there's no need for a stem cell transplant unless there is an acute leukemia or a blast crisis. Blast crisis occurs almost always in CML, which is not really a full-blown AML, but they have basically too many blasts, which are, of course, those immature cells in the blood, and it very much mimics an acute leukemia, and that's very uncommon. Myelodysplastic syndromes treatment vary widely on the subtype and risk level. So in patients with low-risk MDS, they can be monitored with CBCs and transfusion support. If it's high risk, usually they receive chemotherapy followed by a stem cell transplant. Bone marrow failure is difficult to treat because there's not necessarily a malignancy, but rather just bone marrow that can't keep up. So some chemotherapy drugs can be used, as well as growth factor support, to boost the expression of some of the different cells within lineages. But primarily, these patients end up requiring stem cell transplants. And I have the asterisk there because these transplants, usually the regimen to prepare them for a transplant, which involves extremely high doses of chemotherapy and or sometimes whole body radiation, can be very, very poorly tolerated by people with bone marrow failure. So stem cell transplants have pretty poor outcomes in patients with aplastic anemia or bone marrow failure. So here is a great place to start, which is your patient either has leukemia or a family history of leukemia. Now what? So one of the things that I wish I knew before I started doing this was, when do you need to look more closely into a family history of leukemia? It's very unlikely that most genetic counselors in a cancer clinic are going to have a bunch of patients who actually have leukemia. What's more likely is that you are going to see relatives of family members who have leukemia. So in general, 2 or more first-degree relatives in a family diagnosed with a hematologic malignancy should be a red flag. You saw how rare the lifetime risk of leukemia in the general population for acute or chronic is less than 1%. The first step to figure out whether or not you need to look into that further to assess your patient should be to determine whether they were acute or chronic. So in general, an aggregation of acute leukemia, especially myeloid cancer, so AML or myelodysplastic syndrome, in closely related relatives is probably the biggest red flag, or the most concerning for a hereditary predisposition, rather than aggregations of chronic leukemias. So in a family, if you see a combination of acute and chronic leukemia in close relatives, this is less likely to be hereditary. If you see leukemias from both lineages and both relatives, so your proband has CML, the brother had ALL, and father had, essential thrombocythemia, that's less likely to be hereditary. An aggregation of acute leukemias in young people is more likely to be hereditary. So it fits a little bit with what we know are the typical red flags for hereditary cancer, although the lineages and whether they're acute or chronic is important. You're probably saying, but Sarah, my patients don't know if their family members had acute or chronic leukemias, and stay tuned, I've got some tips for you. So if you are proband, or if there is a family history of head, neck, or anogenital squamous cell carcinomas, of course we want to check for other risk factors for that, like tobacco and alcohol use, but those can be solid tumor characteristics of bone marrow failure syndromes, like Fanconi anemia and keratosis congenita. And a proband with a family history of young onset multiple primary cancer should prompt you to also evaluate for Leigh-Fraumeni syndrome, of course. So here are some questions that you can use with your patients in the clinic to help differentiate acute versus chronic leukemia based on the natural history. So if the relative or the proband had to receive chemotherapy treatments in the hospital, this is almost certainly an acute leukemia. Chronic leukemias are often treated by oral chemotherapy, so taking medicine by mouth. Having a stem cell transplant often points towards an acute leukemia. If the relative died of leukemia or complications like an infection shortly after diagnosis, this points more towards an acute leukemia. Having a diagnosis under the age of 50 is more likely to be acute. Problems with the blood counts prior to leukemia, like low platelets or easy bruising, bleeding, or required platelet transfusions, won't necessarily tell you whether it was acute or chronic, but it can point to thrombocytopenia, which can co-occur in families that have a hereditary predisposition. So these are kind of good tools to have to help determine whether or not you should be concerned about a family history of leukemia. If you have a patient who actually has leukemia or myelodysplastic syndrome, this is kind of a list of questions to help assess which syndromes they may be at risk for. I'm going to go through the syndromes, of course, in a differential diagnosis, but this is just a quick reference slide for you. Looking for a history of any blood disorders prior to the diagnosis of leukemia, as well as easy bruising, nosebleeds. Those are all signs, clinical signs of thrombocytopenia, which is the low platelet count, immunodeficiencies, liver cirrhosis, limb abnormalities, and of course other questions getting at keratosis congenita. So here is the bread and butter that I'm keeping an eye on the time so we can get through. So the hereditary predisposition syndromes I've summarized here in this table. So from the dawn of time to about 2009, leukemia was considered to be sporadic. And we've all had, well, we probably learned it in grad school, and we've all had patients who have said, well, my doctor told me leukemia doesn't run in families. So that is being debunked now that we have found up to about a dozen single gene loci that predispose to primarily myeloid malignancies in families. And these families have been reported since the 1920s or 1930s, but because it's so difficult to get germline DNA in these families, especially up until recently with the genetic testing technologies, it's been very difficult to find these different genes, but they have now been discovered and are being discovered as we speak. So DDX41, which is on here, was just discovered in 2015. So this is just basically a slide for you to refer back to, but I'm going to go through the differential diagnosis for each of them. So if you have a family that, or a proband and family who has a familial clustering of acute myeloid leukemia or myelodysplastic syndrome, this is the differential diagnosis. Myelodysplastic syndrome clustering by itself in the family is common, but AML also clustering with myelodysplastic syndrome is also common because the two are related. So there's really only one gene that's been linked with solely MDS. The rest of these AML related genes also apply to myelodysplastic syndrome, so the differential diagnosis overlaps significantly. So the differential diagnosis for bone marrow failure syndrome and ALL are also listed here, which I will go through. So the first on the differential for familial AML is a gene called CEBP alpha. Oh, I made a mistake in the title. I'm sorry. So CEBP alpha is an inherited predisposition to AML only. There haven't actually been any reports of myelodysplastic syndrome. It is nearly 100% risk to develop AML in one's lifetime, has been reported from 2 to 59 years old. And there's no other pre-existing hematologic disease that, or disorder that precedes it. So they are not thrombocytopenic, they don't have anemia. And CEBP alpha is actually a very commonly done somatic test in AMLs because it has a tremendous prognostic implication. So it's very likely that patients in your institutions with AML are being routinely tested for CEBP alpha mutations when they are diagnosed. And in the hereditary forms, what we see is that there are biallelic mutations in the actual AML itself. One of them, usually the 5' mutation, is germline, and a second somatic mutation is acquired in the leukemic progression. And usually there's another somatic GATA2 mutation in there somewhere. We don't know, and this is, you'll see as a recurring theme, we don't know a lot about the prevalence of these syndromes in general. In some cases, it's higher than it was initially probably assumed. About 1% of all AML cases are expected to be due to an inherited CEBP alpha mutation. And right now, genetic testing recommendations and evaluations are all based on expert opinion, but there have been 2 series looking at patients with biallelic CEBPA mutations, and in one of them, anywhere from 7 to 11% of cases that had at least one somatic mutation also had a germline mutation. So at our institution, it is our practice to offer germline CEBP alpha mutation testing to all patients with at least one somatic mutation. Familial platelet disorder with propensity to myeloid malignancies, or FPD-AML, is probably the most well-known to genetic counselors and the most kind of well-described hereditary predisposition to AML. The gene is RUNX1, and this is an autosomal dominant condition that's characterized almost all of the time by thrombocytopenia, an abnormal platelet number, and a mild bleeding propensity, and their platelets can look a little bit funny. It's called basically like an aspirin-like platelet function disorder. And RUNX1 mutations are associated with a 35 to 40% lifetime risk of myelodysplastic syndrome, AML, or very rarely T-cell acute lymphoblastic leukemia, with an average onset of about 33 years old. The prevalence is unknown. There have been about 30 families described in the literature to date, but in the first year of our clinic, which was 2014 to 2015, we identified 6 families, which basically increased the incidence in the literature by almost 20%. So it is not, it is probably not rare. And because the risk for thrombocytopenia is so high, but the risk for leukemia is, high but moderate, these families are probably pretty common in benign hematology clinics for, ITP, idiopathic thrombocytopenia purpura, which is like, you have low platelets and no one knows why. I'm not sure that there's screening routinely being done in benign heme clinics. But genetic testing is recommended in any patient with MDS or AML that has either a previous personal history of thrombocytopenia or a family history of one or more relatives with MDS or AML. So I have 2 of our RUNX1 pedigrees just to show you, and I'm sorry these are ugly because I had to de-identify them. So the first, just so that you all could see what they look like really in practice, I think one of our fears is that we might be missing these families, but they're not subtle. So the proband was diagnosed with AML at 49. Her daughter had easy bruising and low platelets, and we see a sister with AML at 6, another sister with MDS at 57, a brother with non-Hodgkin's lymphoma, a brother with AML at 29. Mom had easy bruising and bleeding. There are first cousins over here, all with MDS and AML. And this family has a RUNX1 mutation, as does this family, which was ascertained when the daughter was diagnosed with MDS at age 7. She had thrombocytopenia and easy bruising. A family history revealed that her father had easy bruising. He came to clinic, was found to have a RUNX1 mutation, and his father had CMML, which is a form of myelodysplastic syndrome. So this one is not as big of a family as the other, but it shows you kind of what these families look like in practice in front of you in my ugly pedigrees. So the next on the differential for familial AML and MDS are the 2 types of thrombocytopenia, thrombocytopenia 2 and thrombocytopenia 5. There is no thrombocytopenia 3 or 4, so we'll have to take that up with somebody. But these are very, very phenotypically similar conditions caused by gene mutations in the genes NKRD26 and ETV6. So NKRD26 is a dominant predisposition characterized by moderate platelet counts, usually about 48,000, which you can see normal is over 140, and there is an increased unknown risk, increased risk of MDS, AML, and CML, and we don't know the lifetime risks or how common this is. But there was a European inherited thrombocytopenia registry that did genetic testing and found NKRD26 mutations in 11% of their registry participants. ETV6 phenotypically is impossible, also impossible to distinguish from RUNX1, which is why panel genetic testing is the easiest, which we'll get to. In general, ETV6 predisposes to almost every type of heme malignancy. And early onset colon cancer has been reported in some families, but they haven't necessarily been evaluated for other hereditary predispositions to colon cancer, so the jury is still out on that one. DDX41 is the newest described AML predisposition gene, which was just described in 2015. Not much is known about it, but most interestingly, patients with DDX41 mutations seem to be diagnosed with AML at an average age of diagnosis, about 65, and they don't appear to have any other blood disorders like cytopenia or thrombocytopenia that present before the diagnosis of AML. And so because these people have no preceding blood disorders, and because they're diagnosed at average ages, it can be really difficult. One of the diagnostic challenges is how to figure out who these people are. So experts have suggested that you should check for a significant family history of leukemia, but because these DDX41 mutation carriers have such a long latency prior to the development of leukemia, it's possible their family members before developing leukemia or have not yet developed leukemia. And so we're working right now to try to figure out how to identify these families. In some families, it seems like a second, they'll have a somatic DDX mutation with a second somatic hit. And so it may be that we can use a similar approach to the CEBPA alpha patients, where if there is a somatic DDX41 mutation, that should prompt a germline evaluation. But that's kind of an evolving practice. So this is a pedigree of a patient with a DDX41 mutation. So the proband was diagnosed with AML at 67. His brother had AML in his early 60s. And interestingly, his brother was a donor for his stem cell transplant, and we are currently testing him to see if he's a carrier because, as you may know, and as we'll talk about, there is a very high risk for adverse outcomes if you use a mutation-positive sibling as a interestingly, his kids have both been diagnosed with ITP, which is low platelets, and his sister also reportedly has a history of low platelets. So we're currently doing some research in this family to see if it's possible that the DDX41 mutation is also co-segregating with the low platelets, which may help define the syndrome a little bit more, in which case everybody has low platelets. So continuing on with the differential for MDS and AML, GATA2 is an autosomal dominant gene that actually can sometimes pop up in pediatric clinics because it causes an immunodeficiency syndrome in some patients. So this by far is the most syndromic esque hereditary predisposition to AML with primary lymphedema, sensorineural hearing loss, cutaneous extragenital warts, and in some cases an immunodeficiency that results in children especially being highly susceptible to these atypical infections. But GATA2 mutations also have a 70% lifetime risk for MDS and AML with a mean age at a very young age, 29. And so even though the overall prevalence is unknown, some small series have looked and have found mutations in as many as 15 to 30% of cases of familial MDS and AML, although we have not picked up any here yet. Familial aplastic anemia, or MDS, with SRP72 mutations is very rare. It's only been reported in 2 families. In this case, it tends to be only myelodysplastic syndrome, although we don't know whether those people could have progressed to AML. And right now, genetic testing is considered for people with 2 or more first-degree relatives with myelodysplastic syndrome, but it's often kind of thrown onto a panel with everybody else, since the phenotypes for these are really not well known. The differential diagnosis for bone marrow failure looks very much like a pediatric clinic. So Fanconi anemia, which is primarily characterized by limb anomalies and dysmorphic features, short stature, and almost all of the kids will have early bone marrow failure in childhood. What's coming out now and has been known, but what we're seeing in the adult clinic is that less than 40 or about 40% or less of patients with Fanconi anemia will not have a clear congenital abnormality. And the lack of these physical features also seems to correlate with a lower likelihood to develop bone marrow failure in childhood. So what we end up seeing is a higher likelihood of getting MDS and AML later in life, in living long enough and without any other reason to be ascertained into a genetics clinic to develop these solid tumors of the squamous cell carcinomas of the head and neck. So the early onset aplastic anemia and bone marrow failure patients should be evaluated for Fanconi anemia even if they don't appear classic. And the multiple genes, of course, you all are familiar with, showing up on in heterozygous state in a bunch of panels, as well, knowing that primarily Fanconi anemia is recessive, although in some cases X-linked, and it's complementation group dependent. And in terms of evaluating patients with MDS or AML, chromosome breakage studies are diagnostic with DEB assay or mitomycin C assay, and much better than genetic testing. Genetic testing is fine, although it presents the possibility of picking up heterozygous carriers of BRIP1 or BRCA2 or PALB2 in children and other issues like that, whereas the DEB assay is diagnostic and will not detect carriers. Swashman-Diamond syndrome is characterized by pancreatic dysfunction in infancy. This is almost always confined to the pediatric clinic. There are very few people with SDS making it to the adult leukemia clinic, which is recessive and has a high risk in childhood. Keratosis congenita is also well known to us from our molecular genetics class, characterized by a diagnostic triad of oral leukoplakia, which are white patches of the tongue and inside of the mouth, reticular skin pigmentation, which has also been described as a lacy skin rash. It's hyper oh, the word is escaping me. It's darker than the normal skin and usually red, and nail dystrophy. And this is a telomeropathy or a telomere maintenance disorder that has a premature aging phenotype. There are 7 reported genes, but the ones most relative to the cancer genetic counselor are probably TERT and TERK, which is associated with a form of dyskeratosis congenita which lacks this classic triad. So in these cases, telomere analysis is the best diagnostic test, which diagnosis of dyskeratosis congenita can be made if the telomere length is less than 1% compared to normal controls. And it's pretty good. It's 97% sensitive, 91% specific for dyskeratosis congenita, whereas we can only find germline mutations in about 50% of patients. The presenting symptoms in the adult clinic and in the families that you or I might see include a familial cluster of MDS and AML, pulmonary fibrosis, or early onset diagnosis of squamous cell carcinoma of the head, neck, or anogenital tract with no other apparent risk factors. And interestingly, this is seen in other familial syndromes, but it was kind of identified first in dyskeratosis congenita, which is that family members who are trying to donate stem cells as a donor for a transplant have difficulty mobilizing adequate stem cells. So they get the medication to stimulate an overabundance of stem cells. And in patients who have hereditary predispositions to MDS or AML or bone marrow failure, they can't make enough. And so sometimes we get referrals from stem cell transplant saying, we had this patient who had difficulty mobilizing, can you check them for genetic conditions? I have just 2 quick pedigrees to show you dyskeratosis congenita outside of a childhood clinic. So the first is this proband with myelodysplastic syndrome diagnosed at 51 who has lung fibrosis. He's been followed at a pulmonary clinic in Houston for a while, and his brother had lung fibrosis as well, no hematologic abnormalities. His father died of lung fibrosis at a young age. They're not particularly short. There was not prematurely gray. Their teeth, his nails are dysplastic, but he doesn't meet the diagnostic criteria for a DKC, but he has a TERK mutation. And this is another young woman referred to our service who has a tongue squamous cell carcinoma. She clearly meets diagnostic criteria. She is very pancytopenic, but her first developing diagnosis, or her kind of first malignancy related to dyskeratosis congenita, was a squamous cell carcinoma of the tongue at the age of 30. Familial ALL is very rare. So there are a couple of syndromes that have, and this of course is different. We're switching from AML and myelodysplastic syndrome to lymphoid leukemia, so acute lymphoblastic leukemia. PAX5 mutations have been reported in 2 cases of familial ALL. Very little is known about that. Lee-Fraumeni syndrome is probably the most well-known association with acute lymphoblastic leukemia, often strongly associated with a low hypodiploid phenotype or cytogenetic pattern of that cancer. There is a recessive gene that's been noted in familial ALL, SH2B3. And then it should always be on the differential for any childhood leukemia, but especially familial ALL, to evaluate for constitutional mismatch or repair deficiency, or CMMRD, which overlaps with NF1 and is the biallelic inheritance of one of the mismatch repair genes. And this is, unfortunately, I have no good answer yet for this family because the proband, who I didn't mark with the arrow, is here. ALL diagnosed at age 1. He actually passed away before we were able to obtain a germline sample, but we do have a germline sample from his sister who was diagnosed with ALL at the age of 10. We suspect they may have CMMRD based on colon cancer and polyps on both sides, as well as some café au lait macules, but stay tuned. It's very uncommon to have familial ALL. So I have a holy grail here because probably the majority of questions I get from genetic counselors are about these lymphoproliferative disorders, CLL, Hodgkin's lymphoma, non-Hodgkin's lymphoma. So there's actually known relative risks of lymphoproliferative tumors in first-degree relatives of patients with these cancers. And because these all arise as B-cell lymphoproliferative neoplasms at different points, someone who has, or a proband any of these, their relatives have a risk for not only that form of LPD, but also others. So I get a lot of questions from genetic counselors who have, a patient with Hodgkin's lymphoma, and maybe their brother had NHL and their father had CLL, and really these are all diseases that arise from the same spectrum. So the CLL risk, usually this 8-fold recurrent risk or relative risk is the most commonly quoted for first-degree relative risk for CLL. But individuals with any of these cancers or the proband and the risk of the relatives is all here in this chart, and I've created this legend. So this is probably I put the holy grail on it. It's probably what you all wanted to get out of this talk to begin with, because these are the most common that we see in clinic, because they are the most common types of hematologic malignancy. We also know the least about them. So there are no single genes that have been identified, and not very helpful genetic testing to date. So speaking of genetic testing, I'm keeping an eye on the clock. Genetic testing for some of these genes is clinically available. This is not an exhaustive list, but Prevention, GeneDx, Ambry, University of Chicago, and VTA, Baylor, and University of Washington all have some form of familial leukemia panel or bone marrow failure panel. There's fewer options for single genes. And the panels vary widely in what they include. In my personal experience, I feel like lymphoma panels are the least useful because the differential diagnosis for lymphoma is primarily Li-Fraumeni syndrome, and that's about it. And outside of childhood, where of course you would want to consider CMMRD. But in general, the University of Chicago Tier 1 familial MDS-AL panel is the most comprehensive. It is every gene that's on the differential diagnosis that I presented for MDS and AML, but does not contain the other stuff that we typically don't want. But the tissue selection is really where most genetic counselors get into trouble in terms of selecting a lab or just being able to access the test that they want. So for example, University of Chicago doesn't culture fibroblasts. So they will do the testing on fibroblasts. In fact, they really only do testing on fibroblasts, but you have to be able to have it cultured and send the flasks there. And that really limits where genetic counselors can send genetic testing for these genes in patients who actually have leukemia. So in leukemia, the peripheral blood is a tumor tissue. It's as good as testing a biopsy from a colon tumor. And so you can really only use skin fibroblasts as the source of germline DNA for genetic testing. Saliva and buccal swabs contain a significant number of peripheral-derived cells, and that's primarily because these patients who are thrombocytopenic have subclinical bleeds in their gums and within the mouth, and so there's usually a high percentage of leukemia cells within saliva or buccal swabs or donor contamination from patients with allogeneic stem cell transplants from related or unrelated donors. A skin punch biopsy is not that big of a deal. It's a lot harder to coordinate than it is to actually do. So I've just put a quick kind of picture here of how it's performed. A 3mm punch is usually what most labs require, and really the limitation is that the labs must be in a CLIA environment before they're testing, and there's very few genetic testing labs that will culture in a CLIA environment. MD Anderson does not culture. We can culture fibroblasts, but we're not CLIA certified. So we have primarily used GeneDx and Mayo Clinic, both of which will CLIA culture our fibroblasts and perform the genetic testing. So this slide is primarily to serve as a little bit of a reference for you, kind of a checklist, so you can check what your patient has and see what the best options are. So if a patient has an active blood cancer of any kind, a skin punch biopsy is really the only specimen that a lab should accept. If a patient's had a transplant from a related or unrelated donor, the skin punch biopsy is your only option. Autologous stem cell transplants, so receiving a stem cell transplant from one's own stem cells, is almost never a treatment for an acute leukemia, but it's pretty common in non-Hodgkin's lymphoma. And peripheral blood can be used once the patient's in remission after transplant, because that's their own stem cells. Acute leukemia in remission is kind of dicey. So AML patients, for example, have a persistence of acquired mutations even if they are in a morphologic remission on their bone marrow biopsy. So if a patient is in a morphologic remission on bone marrow, has a negative minimal residual disease test on flow cytometry, you can probably use blood. But if you're asking yourself if it's okay, a skin punch biopsy is probably still the best bet. With the increasing sensitivity of next-gen sequencing, I personally find it a little bit worrisome to take a risk that you could detect a somatic mutation if it's at a low level in the blood, which of course it would be. So that's just something to think about. And chronic leukemia does not ever achieve a complete remission. So you can have a chronic or a remission phase of CLL or CML, but those leukemia cells are persistent. So patients with chronic leukemia should receive skin punch biopsies. Genetic testing in these families has similar, but not all, of the same benefits, risks, and limitations that we have for all of the other genes we test for on a daily basis. There is actually a slight increased risk of the actual genetic testing procedure from the skin biopsy. It can have bleeding in patients with thrombocytopenia or an infection. Those can be mitigated pretty well. But treatment and cure of leukemia often so much depends on family members, which is unique compared to our patients with breast or colon cancer, for example. And so oftentimes a patient's best chance of a cure depends on someone who's related to them. And since these genes are inherited, we run into ethical issues and really just medical care issues in which genetic testing needs to be urgently performed on HLA match-related donors to avoid using mutation carriers. And that makes it hard on the family members, makes it hard on the patients, but there are well-published, significantly increased adverse outcomes of stem cell transplants in patients who are transplanted with family members who are also mutation carriers, meaning the graft doesn't engraft, there's an increased rate of relapse, and actually the newly acquired hematologic system from the donor stem cells can actually then just develop into a primary leukemia. And so that makes it difficult for some of these families where the treatment is just really burdened by the possibility that they may or may not survive their cancer based on this inherited predisposition limiting their donor options. The other thing harkens back to kind of the early days of Li-Fraumeni syndrome, which is that there's no risk-reducing or preventative actions that can be done to reduce the risk of developing blood cancer in these syndromes for the most part. So surveillance and treatment recommendations are better established for some of them, like Fanconi anemia, versus flying by the seat of our pants on other ones, which primarily are bone marrow biopsies at diagnosis and CBCs every 6 months to a year. And you have to kind of weigh the risk of being able to provide surveillance for some things, like screening patients with keratosis congenita for head and neck squamous cell carcinomas, versus also identifying that they're a risk for a cancer that can't be adequately prevented. And the penetrance is so variable. CEBPA is basically 100% risk. SRP72 is a big question mark. So right now, it's difficult since panel genetic testing is by far the most appropriate testing for these patients, since the phenotypic overlap is remarkable. How do you adequately counsel a patient that this test may come back saying that you're at 100% risk for AML, or it may come back with something that we don't know about. And surveillance is not very well established at this point. And, we have a chance of burdening the treatment process. Like I said at the beginning, these patients are in general poorly adjusted to their diagnoses on a psychosocial level. And now there's also the possibility that their best donor may not be a good option if they are positive for the mutation, and if there's no unrelated donor available, sometimes we still proceed with the mutation positive donor, but that can be a difficult thing for patients to deal with, and it's raises some ethical issues. And really the main benefits are for genetic testing in these families is to reduce uncertainty, and early detection and treatment for intervention for leukemia may improve the outcome. Families who know they're at risk can determine who is a mutation carrier, who is not, without the pressure or urgency of a blood cancer diagnosis, and can even secure unrelated donors. And there is actually a great potential for chemoprevention in these patients. There are drugs that target early clonal development in patients with myelodysplastic syndrome, and so there is some promise that that may be able to be used in patients who are at high risk for an inherited blood cancer. Here are my references, and with 4 minutes to go, I am happy to take questions.
Thank you so much, Sarah. That was really wonderful. I enjoyed learning about that. We do have some questions. I think one question we got from multiple people is about Sarah's slides. So she has generously offered to let us put her slides as well as a recording of today's webinar up on the Cancer SIG webpage. We are going to go ahead and put slides and recordings from all of our webinar series up there so you can always access those. All right, Sarah, let's start at the top. This question reads, my cancer center has a large BMT clinic and we virtually never work with them. You mentioned some testing that might be done on patients already. Do you think it's worth developing a checklist or intake sheet that the clinic could use to identify patients that would benefit from seeing a genetic counselor and getting a full family history?
Absolutely. Absolutely. The scariest thing that I've encountered in our leukemia clinic, which is one of the largest in the world, is that they don't take a family history. And not like don't take a family history like other doctors don't take a family history. Like sometimes it's not even included in their reports at all. So I think that is a great idea, especially because a relatively short checklist could probably be used to identify your low-hanging fruit. So if they're doing, every patient who's diagnosed with leukemia has genetic testing done on their leukemia, every single one, because so much of the treatment is based on targeting different genetic somatic mutations. So, you know, the first thing I would recommend would be to have some sort of system set up wherein the low-hanging fruit is, you know, any patient who has a CEBP alpha mutation identified in their AML, or RUNX1 is also on many liquid tumor somatic tests, as well as having them just take a standard, you know, do you have a family history of leukemia, or do you have a close relative with leukemia? We think that 5 to 10% of patients with leukemia have a first-degree relative, and that might be a way to get access into that particular clinic, and then being able to identify first the most common families and then hopefully building a relationship with them. But I would be happy to help anyone, or I don't know, can't open myself up to everyone, but maybe it's possible we could have a working group or something to do that if it would be helpful.
That's great, Sarah. Thank you for offering that. Next question is a specific case. I'm actually sending a sample to UChicago this week, and they indicated that I could just send a skin biopsy and they would do the culture. Perhaps this is because the patient will be involved in their research through that lab. Not sure why they will accept skin in this case.
Me neither. Congratulations. That's good. Good. I definitely think that you should. It may be. I haven't. We, like all of you, we have different institutional guidelines that determine where we can send different samples. So the University of Chicago is where the two main researchers in hereditary AML are Jane Cherpek and Lucy Godley. And actually, I don't know if they have a genetic counselor, so if you're out there, give me a holler. But next to us, they're probably the other biggest familial leukemia clinic, and their testing, I think, is really good. So if they'll culture yourselves, then go for it. GeneDx cultures fibroblasts for us directly for free, and they will do any test on fibroblasts, and they do their same insurance policy for our patients. So if you send to them routinely, they're an option for you, in case that's helpful. I don't mean to endorse any lab, but that's what we do.
Okay. On that vein, what has been your experience with insurance coverage of genetic testing for your probands? And then what about for their family members considering donation?
I have not had any patients where the testing was not covered with, you know, outside of the genetic testing actually, incidentally, the only denial I've had is for a patient who had an exclusion against genetic testing, and she was just a single-site BRCA testing that we had to do a skin biopsy because she had CLL. So I have had no problems with this being covered by insurance, or no problems that I'm aware of. It hasn't made it back to me if there has been a problem. And we've also had no issues with the skin punch biopsies as procedures being a problem with them covered by insurance. Genetic testing in family members, we have also had no problems, probably because this gets coded the same as a known familial mutation in any other gene, which insurance companies usually cover. So I have fewer problems with insurance in my leukemia clinic than I do in my GI clinic, probably because it doesn't have enough awareness yet, but I have had no problems.
Okay, great. Next question. In time-sensitive situations, for example, transplant from a related donor, do you consider using buccal or saliva in place of skin biopsy given the added time for growth of fibroblasts?
So in those cases for, sorry, let me clarify. Is that genetic testing in the family member to see if they're carriers, or in the proband with malignancy?
It did not specify.
It didn't say. So honestly, no. Unless if someone has ALL and they are in a complete remission, so ALL seems to have deeper remissions than AML, which is highly technical but true. In ALL, if they're in complete remission and we have a window before they go to transplant, we would probably feel okay using saliva or buccal. Of course, ALL is almost never hereditary, so that situation doesn't usually happen. With AML, usually we're testing them while they're still undergoing chemotherapy, and then it takes, the chemotherapy to get them into remission takes at least 4 weeks. So we have had and then it takes usually another 4 weeks to get them to transplant. We have not run into a situation where we couldn't get genetic testing back in time for the transplant, and actually we've also had our transplant teams being willing to wait for the genetic test results instead of to risk rushing them. I'm getting results back in 4 to 6 weeks, even with the culture, even with the fibroblast culture. So it does add about, I would say in general it adds about 2 weeks to the process, but it would, if you can, I would always use the fibroblast, and we have not done buccal or saliva in somebody who has an active malignancy in that situation at this point.
Okay.
In family members, though, we have. If we know the mutation, we easily just send saliva kits because, of course, their relatives aren't affected, and that we can get results back pretty fast.
That leads us nicely into the next question. As family members who are potential donors may have very early stage asymptomatic disease, should you consider skin fibroblasts on them as well, or do you think blood is okay?
So as part of their screening to see if they're even eligible donors, they get CBC. And so one of the things we found, for example, in our RUNX1 families is that if they don't like just anybody as a donor, so even if they're not a mutation carrier, they can have other things that screen them out. Like if you're thrombocytopenic, you can't be a donor, even if you're not a mutation carrier. We don't understand like the early clonal evolution in those patients with like a RUNX1 mutation who hasn't been diagnosed with a malignancy. So in these cases, we are still doing blood on them because we're trying to figure out if they're carriers to begin with, and so we haven't gone so far as to require skin punch biopsies in family members, mostly because the likelihood that they would have a somatic mutation that would be detected in place of the germline mutation is very low, but that's actually a really good thought. I think we would probably want to confirm, the thing is you would want to confirm that if you found like then somebody, was RUNX1 positive, but they weren't thrombocyte, it gets kind of sticky. But in most cases, we are still using blood for genetic testing in family members and then a bone marrow at diagnosis if they're positive, which kind of clears everything up.
Sarah, we're currently at 5 minutes over the hour. Are you still okay to keep taking questions? I don't want to.
Oh, yeah, sure.
Okay. The next is actually a comment. She says, I don't have a question, but this was awesome. So
Oh,
I think
thanks.
this topic was well received. All
Tell
right.
your national genetic counseling sponsors or whoever.
Okay, two quick questions from the same person. Can you repeat the internal criteria that you use for Rung X1 testing?
Sure. Let me see, I can go back. We do RUNX1 testing in any patient with MDS or AML who has a personal or family history of thrombocytopenia or personal or family history of MDS or AML. We also, so I didn't even get into this because this is such complicated testing for 60 minutes, 55 minutes of everything you need to know about hereditary leukemia. But the somatic mutation results we use to figure out who should be screened as well. So the data coming out of Chicago shows that they purport that any patient with a RUNX1 mutation, or really any somatic mutation that you check for that's relevant, between 20% and 90% allele frequency in the leukemia should be tested in the germline. We are such a huge center. We see almost 900 new leukemia patients a year that if we followed that criteria, it would be my full-time job, 24 hours a day, and like skin biopsies would be like falling out of our institution. So primarily, if a patient is diagnosed with like a young MDS or a young AML and has a history of thrombocytopenia, or they don't quite fit that criteria that I listed, but they have a RUNX1 mutation in their leukemia, we will very often confirm whether it's germline. In fact, any patient with a RUNX1, CEBPA, GATA2, or TP53 mutation that is somatically found at around 50% allele frequency, we see all of those patients for germline testing. That was a little more than that question bargained for, but there you go.
Interesting. The second part of the question is that she has had some pediatric oncologists note that they would go to BMT quicker if there's a heritable predisposition with heme symptoms. Can you speak to that?
So I'm guessing they are thinking primarily about Li-Fraumeni syndrome or RUNX1 or things like that. Yes, in the sense that in some cases, especially with Li-Fraumeni syndrome, for example, the most common one they probably deal with, sometimes the leukemias can be more aggressive or higher risk to relapse. So leukemias have to stay treated with chemotherapy after they go into remission because there's a high risk of relapse. So my guess is that based on the rationale would be that if a patient is at high risk for relapse or high risk for a second cancer, they would go to transplant sooner. Why they would tell you that, and hopefully they're screening their patients and referring them to you. The other thing that can happen is that patients with these genetic susceptibilities are also at higher risk for those therapy-related MDSs. So patients treated with AML who have RUNX1 mutations who go into remission and don't require a transplant are at higher risk to get a therapy-related MDS. So treating them for one blood cancer can give them another blood cancer. And so that may also be what they're thinking, is that if they have kind of one shot at this patient, for example, that if they have an inherited predisposition, they'd rather take them to transplant sooner rather than later.
Okay. What about an infant who needs a bone marrow at baseline, quote unquote? Any thoughts about when that should be done in children?
So bone marrow biopsies are pretty safe, depending on these, in terms of invasive and risks of complications and everything like that. In terms of the particular syndromes that I talked about today, the bone marrow biopsies of diagnosis usually we probably would not do until probably outside of CEBP alpha, which has the youngest diagnosis. We would probably recommend a bone marrow biopsy in kids around the age of 5 or 6 at diagnosis. And as far as that's concerned. Most kids do totally fine. They are, lightly sedated, and the biopsy itself is of course, not that hard. But we haven't had to do too many, mostly because we are picking up adult patients who have relatively older children. So we see the pediatric patients, but by far I'm seeing the adult patients. So I guess an infant who needed a bone marrow biopsy, my question would be kind of what did they need the bone marrow biopsy for? I think it would probably, if it's just simply because they tested positive for one of these gene mutations, I think an infant, timing and genetic testing and all of this is just not even established. Anyone who wants to do a project with me, I'm totally open to it. But in general, we haven't been testing infants, but I think you could probably wait to do a bone marrow biopsy.
On the table that you presented of risk for first-degree family members for the various disorders, why do some of the risk numbers have a minus sign after the number?
That's a good question. So that is a range. I'm happy to, when I send out, so actually the reference for the table is at the bottom of the slides, and since I'm going to give the slides to NSGC, you guys feel free to go and read the paper. It's great. It's a super great review about lymphoproliferative disorders. So it's actually a range. So basically the bottom of the range in these were statistically significant, so P less than 0.05. So that's what that is indicating.
Thank you.
Yeah, it's a review paper, so they, or kind of a meta-analysis. So they reported all of the different ranges from each of the different studies, and at only one certain point or below was it statistically significant. But a really safe, relative risk to quote to patients with any of these non-Hodgkin's lymphoma, Hodgkin's lymphoma, multiple myeloma, and CLL is basically up to 8% relative risk in family members, which is low because the risk for all of these things is 1% or less. So, I mean, we're really talking about pretty low risk to family members.
Okay. In response to what you had mentioned about University of Chicago, there is a new genetic counselor working with Dr. Chirpik and Dr. Godley, just for your knowledge.
Oh, great. Hi, person.
Okay. Now, are there any ethnic predilections that you're aware of?
Not that I'm aware of.
Okay. Well, that was an easy one. Next question. DEB is supposed to be very good for diagnosis, but I heard it was specific to the clinic and it could be inaccurate. If you had abnormal EBS but negative FA panel testing, are there other conditions in the differential?
For Fanconi anemia, so that's interesting. We haven't had that experience with DEB, or I haven't heard of that, it being unreliable. So if the differential is for the aplastic anemia or bone marrow failure and the DEB assay or the sequencing panel for Fanconi anemia is negative, I would also do telomere analysis for disc keratosis congenita because they can overlap very closely. Bone marrow failure panels, GeneDx has one through SLICE and Chicago has one, and they have also include the 18 known genes related to Swashman-Diamond syndrome. They include Diamond-Blackfan anemia is the 18 genes, Swashman-Diamond syndrome, SBS. So that might be another way to approach it, is to do a more broad bone marrow failure or aplastic anemia panel up front. But otherwise, if Fanconi anemia, if the testing is negative, the DEB assay is negative, and they don't have another bone marrow failure or aplastic anemia, you may be looking at a, idiopathic aplastic anemia or bone marrow failure.
Okay. Is there anything else that would cause abnormal EBS?
EBS. What's the definition of that?
I'm sorry, I don't know. Maybe chromosome breakage?
Let me see, I can look it up.
Sorry, DEB. She said, sorry, DEB.
Oh, is there anything else that would cause an abnormal DEB? I think To my knowledge, no. So it's assessing the chromosome breakage that is specifically caused by the complementation failure of the with that happens within Fanconi anemia. I mean, Nyman breakage syndrome, NBS can also cause chromosome breakage, but I believe they look different. And this is, primarily in the PEDs. You guys seen my patients with Fanconi anemia or I didn't show their pedigree, but I have, adults with Fanconi anemia who didn't have any of the other signs. But the Nyman or Niemann breakage syndrome is also a chromosome fragility or breakage syndrome. To my knowledge, they have different characteristic breaks, but that would also be in the differential diagnosis. Okay. I think it's treated with a different chromosome stressing agent, but whoever you are, email me and I'll get back to you.
She said thank you.
Mm-hmm.
All right. Would a biallelic somatic mutation in any of these genes prompt you to consider germline testing?
Yes. Okay. That would be really unusual.
Okay. Are non-family donors screened for mutations in these genes prior to donation?
They're not, as far as I'm aware, within the National Bone Marrow Registry, which I highly encourage you, if you're not a member of the registry, become a part. I don't work for them or anything. But as far as I'm aware, no. But generally, they are, somebody who is a potential, they are just screened for HLA, to my knowledge, although admittedly I have not done extensive research into this. But once someone is selected as a possible match, they undergo a battery of testing to determine if they are a suitable donor. To my knowledge, genetic testing is not a part of that. Okay, but I'm going to look into it now.
Okay, now regarding that family that you showed us that you were still curious about, how are you testing for CMMRD in your family? This genetic counselor works with about 50 families with that condition through an international consortium, and they have found confirmation tricky in some families. They do have functional assays and non-traditional testing outside of IHC and MMR germline, if you would like.
That would be great. So I didn't get into this either, but we have a whole exome study for any of our families that are negative for germline genetic testing clinically that appear to have really any two or more patients with leukemia. We are enrolling them for a whole exome. So that family was extremely complicated. We didn't end up being able to do any clinical testing on him, but we have his bone marrow, which unfortunately in his 6 short years of life was almost never in remission, and his sisters and his parents. So right now we're just doing, we're just doing whole exome, so we're banking on finding just a biallelic germline mutation in his sister and heterozygotes and his parents. But that testing analysis is still pending, and that was our plan with the best that we have. That was our plan for them right now.
Okay. I think you've made it to the last question. Is
Great.
there a familial MPN, such as polycythemia vera, or are there any appropriate genetic testing?
Yes. So familial polycythemia vera is an entity. So there are not very many people diagnosed with familial cases of polycythemia vera, but the gene JAK2 is almost pathogenomically mutated somatically in patients with polycythemia vera, and the most common mutation, which is V617F, V as in Victor, 617, F as in Frank, has been reported to be germline in some families with familial polycythemia vera. So interestingly, you guys didn't bargain for this, but JAK2 V16F germline mutation testing is patent protected, or the somatic testing is patent protected, similar to the old era of BRCA. So there is no clinical JAK2 germline V16F testing allowed in the United States. So we have been putting all of these patients on our whole exome protocol and doing it on a research basis, but their JAK2 is so far kind of the biggest candidate for these familial polycythemia vera families. And it's similar, like polycythemia vera, myelofibrosis, essential thrombocythemia appear to be similar in terms of their risk within families as the lymphoproliferative disorders like Hodgkin's and CLL. So it seems like there are increased risks kind of across the MPNs as there are across the LPDs. So JAK2 should be on the top of your differential for familial polycythemia vera. And good luck getting it tested.
Well, those are all the questions that we had, Sarah, and thank you so much for staying 20 minutes late to answer the questions.
Great,
really
sure, no problem.
And
I'll send you the slides.
All right, that's wonderful. So we're going to go ahead and end the webinar now. If anyone has any questions or any concerns, you can always post on the discussion forum or you can email me directly. Take care, everybody.